don't need a Word document for this, so I can just briefly say that.
It's fine. Thank you.
No, but let's get 20 seconds. That he's, a former president of the American College of Gastroenterology. Has been, as I said, really leading the charge in IBD for the past few decades. He was at the University of Chicago for a long time, and now is running the Digestive Institute at Northwestern. Is that short enough, Dr. Hanauer?
Perfect. And as Dr. Weiss mentioned, this is really a great pleasure. Two of my favorite people in the world are Maria Abreu and Roy Weiss. And it's kind of ironic that instead of me visiting Miami and having a fabulous dinner at Dr. Abreu's house and enjoying meeting all the people there, I have to invite you into my house here in Chicago. Indeed, yes, this is the first time in 8 weeks that I put on a tie. And I know the number one question that everyone is asking regarding this presentation, so I'm going to answer it right now. And the answer is, yes, I'm wearing pants for the presentation. But I can't promise you how long they will stay as formal pants. And I think that this tie is going to come off as quickly as the presentation goes. So it is a real pleasure to bring Coles to Newcastle and to talk about studies in inflammatory bowel disease to University of Miami, where Dr. Abreu's been there for a decade, I think. And by the way, regarding Dr. Weiss, he reminds me that we go back even further. I believe that I was on the internship selection committee at the University of Chicago when we had the foresight to bring Dr. Weiss into the Department of Medicine as a medical intern. And of course, I'm very fortunate to have worked with him as he rose up through the ranks into endocrinology, became a professor and then vice chair of the Department of Medicine at Chicago, where he was a superb boss. And I think that everyone was envious that he decided to move down to Miami to take over there. He's a wonderful individual. I continue to consider him a great friend. And you're all very fortunate to have this dynamic duo with you there. So I'm going to start with a couple of very brief cases in the presentation to exemplify where I'm going to be heading with this discussion. The first is a 50-year-old man who was in good health until 1 year after he'd stopped smoking. He then developed rectal bleeding and frequent bowel movements, and a colonoscopy demonstrated that he had left-sided ulcerative colitis. He was started on the usual string of medications, from mesalamine agents to corticosteroids to azathioprine, and eventually was started on an anti-TNF biologic, but was still frustrated by persistent symptoms until he started smoking again, about 3 to 5 cigarettes a day. And after that went into a complete remission and is now off of all of the other medicines, but continues to smoke about 5 cigarettes a day to maintain his remission. So that's just one example of what we'll discuss as a human model of inflammatory bowel disease. A second patient is a 30-year-old woman with Crohn's disease who is refractory to medical therapy, who undergoes an ileal resection and a temporary diverting ileostomy. At follow-up, there was no evidence of recurrence within the small intestine until she underwent reversal of the ileostomy and had an ileocolonic anastomosis. And then she was demonstrated to have a recurrence proximal to that ileocolonic anastomosis and required a litany of therapies after that. So 2 examples of where I think that we can be studying inflammatory bowel disease in humans to understand better the underlying pathogenesis. Now, this is the biopsy from a normal colon, and I may have actually stolen a couple of these slides and many others in the presentation from my colleague, Dr. Abreu. So some of you from Miami in the GI division may recognize some of these. But this is a healthy colon, and you can see the colonic crypts that are present, and between the crypts are what are known as chronic inflammatory cells. We see macrophages and some plasma cells, but what we do not see are neutrophils. In contrast, on the next slide is a patient with active inflammation. In this biopsy of the colon, you can see that the crypts are more hyperchromatic because they've lost mucin in them. They are also, in between the crypts is congestion of not just those chronic inflammatory cells, but also acute inflammatory cells such as neutrophils that are infiltrating this crypt in this place right now. And this is known as a crypt abscess. So this is a colitis. This is an active colitis. And endoscopically, what this looks like is endoscopically a normal colon with an intact mucosa and shiny and glistening. You can see the mucosal vascular pattern, but when the colon gets inflamed, we see that epithelial cells are disrupted, they are ulcerated. But the colon, under normal situations, has the ability to repair itself. So I cannot distinguish, frankly, whether this is a Salmonella or Shigella or Campylobacter infection from chronic inflammatory bowel disease. Sometimes there are subtle microscopic differences, but for the most part, they behave very similarly. But in an individual who has Salmonella or Shigella or Campylobacter, their colon then goes back into normal appearance with the normal appearing crypts and the absence of neutrophils. So under normal situations, the colon does have its ability to repair itself and go back into normal. And over the past decades or so with ulcerative colitis, we've actually found that the same thing, that the colon is able to repair itself. We call that mucosal or endoscopic healing. And we also know that histologically, the colon can actually go back to normal where we didn't think that it could in the past. So this is an example of a patient with inflammatory bowel disease, and it emphasizes what inflammation in the intestine actually looks like. Ulcerative colitis and Crohn's disease are relatively new diseases over the past 50 or 60 years in the West, and are now in epidemic proportions in areas where we did not believe the disease existed in the past, such as in China and in India and other places in Asia. And we're starting to see this now as a worldwide epidemic, where the incidence and prevalence has begun to level within the West for both ulcerative colitis and Crohn's disease. As you can see around the world, these diseases are actually increasing. And the plateau in the United States has left us with the estimate by the Center for Disease Control of about 1% of the US population having either ulcerative colitis or Crohn's disease, with up to 3 million cases diagnosed just within the past several years. So what's happening in Asia to increase the incidence of inflammatory bowel disease? Well, genetics haven't changed in that period of time. It's pretty obvious that diet is and the environment are some of the biggest differences that have led to an uptick of not only the chronic immune inflammatory diseases, but also obesity in Asia. So we are seeing a worldwide epidemic and still looking for what contributes to the underlying pathogenesis of inflammatory bowel disease around the world. Now, if I was speaking on rheumatoid arthritis or psoriasis, I'd be giving many of the same epidemiologic concepts that we're talking about with inflammatory bowel disease. But the gut is somewhat different, significantly different from the joints, which are essentially sterile, and the skin, which is more impervious to environmental antigens. In contrast, the gut is primarily an immune organ. It's obviously very relevant for digestion and absorption, but it is the largest immune organ within our body. And it needs to deal with the billions upon billions and trillions of bacteria and microorganisms that are present within the digestive tract, such that there are probably 1,000 times more bacteria within our gut than there are cells in our human body. And so our intestinal tract not only needs to be able to absorb nutrients, but it's well endowed with immune and inflammatory tissues that are able to signal what is present within the lumen of the bowel, to sample the individual microbial species, including different types of bacteria, different types of viruses and fungus. And in usual situations, we are staying in balance with these commensal organisms. In inflammatory bowel disease, and possibly also in other immune-mediated diseases, there is an intestinal dysregulation where we have recognized that the bacterial populations are different in patients with IBD and also with other immune-mediated diseases. There is a less diverse population of microbes, and we've learned through this epidemic and through the decades that diversity across the board, and including within our intestine, is actually a good thing to have. When it's less diverse, and we don't know whether this is a chicken or egg, but we have a change in the bacterial and microbial populations that are associated with mucosal ulcerations, and hence also increased exposure of the underlying immune system to the potential antigens that are present within the gut. But we've recognized now that in inflammatory bowel disease and the other immune-mediated diseases, that these have become very complex immunoinflammatory processes. And we're recognizing that there are several contributing factors to the development of these chronic inflammatory diseases that include features from within the environment. And now we include the gut microbiota as part of our environment, our own genetics, and how our genes have regulated, along with the bacteria and antigenic exposure, the underlying immune system. So IBD, just like the other immune-mediated diseases, are really complex and very heterogeneous in their ultimate phenotypic presentation. And part of that is because of this process of protection, active inflammation, and then subsequent downregulation of the inflammation, that we're not seeing inflammatory bowel disease across the decades in an individual patient necessarily as a single disease, but it's actually maybe going through different phases, and the immune system may actually be modified along those lines. So just as an example of that, many of us are familiar with patients who may be in remission for many years on a drug such as infliximab or another maintenance agent, and then all of a sudden they have a flare-up. We measure the amount of infliximab in their bloodstream. We find that there's plenty of infliximab there, but yet there are no anti-infliximab antibodies, yet the patients stopped responding. And in that situation, they tend not to respond to another medicine within the same class. So we are frequently seeing examples of how the immune system or the pattern of disease may actually change from being in a homeostatic pattern on the left, active inflammation in the center, and then a resolution of that inflammation. Now, there are differences between ulcerative colitis and Crohn's disease in how these patterns actually evolve. And one of the main differences is that Crohn's disease tends to be a deeper inflammation within the mucosa. And one of the results or associations of that deeper inflammation is actually fibrosis and the development of strictures, and also the potential for transmural inflammation to attach to an adjacent organ in which we would consider or call that a fistula. So even within these diseases, there's some diversity within the patterns of these diseases. So I want to go back very briefly and give a 20,000 foot view of the different components as we're currently thinking about them in the pathogenesis of ulcerative colitis and Crohn's disease. Now, when I was back at the University of Chicago, my mentor, Dr. Joe Kersner, and Dr. Weiss remembers Dr. Kersner very well. He was one of the first national and international figures who was really forced into studying inflammatory bowel disease, where many other gastroenterologists did not want to take up this uncommon disease in the 1940s and 1950s and 1960s. But one of the first important revelations, and actually Dr. Kersner had several. One was he also felt that the microbiome was abnormal, and in his early animal models that were done in association with colleagues at the Mayo Clinic, they thought that they had identified abnormal bacteria in the intestine of the patients with IBD, but that was found to be probably erroneous. On the other hand, at the same time, he was recognizing that there were patterns of the disease within family members. And as we've learned, the epidemiology of ulcerative colitis and Crohn's disease have recognized that there does appear to be a genetic susceptibility. And this goes back 20 years now to some of the twin studies that were done in Scandinavia that recognize that patients where siblings with inflammatory bowel disease were much more likely to be concordant if they had Crohn's disease than if they had ulcerative colitis. So monozygotic twins had a much greater incidence of concordance than patients with, one of these should be ulcerative colitis, my apologies. So we recognized that there was a greater concordance and likely a greater risk of genetic contribution or genetic association with Crohn's disease. And then it was in about 2001 that our colleague Judy Cho, who was at the University of Chicago at that time, along with investigators at the University of Michigan, recognized the first mutation, what's known as the NOD2 or CARD15 mutation, that was associated with patients with inflammatory bowel disease. And over the past 20 years, there's been what's called essentially a genetic gold rush of patients that now more than 200 mutations have been confirmed to be associated with ulcerative colitis or Crohn's disease. Many of these actually are associated with either of the disease, and a few of these have been relatively specific. But I point out on this slide that the same genetic mutations are not unique to inflammatory bowel disease, and they can be commonly seen in other conditions such as ankylosing spondylitis and psoriasis, and as Dr. Weiss is very familiar, in type 1 diabetes. So on the other hand, the different way of saying it is only about 15% of patients with inflammatory bowel disease have one of the known genetic mutations, meaning 85% of patients do not have a recognized mutation. On the other hand, of all the patients who have a NOD2 mutation, it's only a very small percentage, probably only 1 or 2%, that actually have inflammatory bowel disease. So the genetic types, at least in the adults, and we'll get to children later, seem to be allowing the potential for the disease, but are not considered causative. And in the largest genetic study over the past several years of over 30,000 patients, it appears to be that there may be a spectrum of disorders with patterns of ileal disease or colonic Crohn's disease or ulcerative colitis, but these patterns are not necessarily persistent. And through the past several decades where we've recognized, where we've been performing colectomies and ilioanal anastomoses on patients with what we've considered to be bona fide ulcerative colitis, we still see several percent of these individuals who go on to develop patterns that are more consistent with Crohn's disease. So we're still looking for genes, and we're still trying to identify their importance. But I point out with this somewhat sarcastic joke or sarcastic slide that it's not necessarily all in our genes. And here are two individuals who have the same genotype, but clearly different phenotypes. And it's pretty obvious that there are going to be post-genetic modifications, whether epigenetic or others, that are contributing to the individual phenotypes that we are seeing. Now, along with the immune response, we are increasingly aware now that we are living in association with our microbiota. And I've already pointed out that only 0.1% of our genes are really unique, that we share many of these genes with other species, and that we have far more bacteria and microbes within us than we have human cells in our body. Not only that, there's a lot of clinical evidence and clinical observations that suggest a role for the intestinal microbiome in the disease pathogenesis. The diseases are located in areas of highest bacterial populations. We've recognized mucosal associations and translocations of bacteria. And indeed, I caution you when you are reading microbial studies that if you're looking at what's going on in the feces, that does not necessarily represent what's going on with different segments in the bowel with microbial species that are actually lining the intestine. And you also need to be careful about studies that look at bowel preps and then biopsies, because we're learning that bowel preps with polyethylene glycol can actually wash off the mucus layer and the mucosa-associated bacteria. So you often have to study this in its nascent phase and actually get unprepped samples to really find a representation of what's going on within the mucosa. I mentioned early on in that the second case of the patient with Crohn's disease, in a finding that was recognized again over 20 years ago by Geert Daans now at the University of Amsterdam, that when he was in Leuven in Belgium, they had recognized that patients who had diversions of the small bowel proximal to an anastomosis, that the patients did not develop recurrence of disease until the anastomosis was actually bathed in the intestinal stream, when they were reconnected and the bowel was put back into continuity. And we see that today frequently in individuals who have diverting ileostomies. They do not develop Crohn's disease until you put them back into continuity and expose them to the anastomosis and that same sites to bacteria and or bacterial products. So there are many other clinical observations that suggest the role of bacteria within these diseases, including some patients who actually have symptomatic improvement, and I'm not saying remissions, but symptomatic improvement with different bacterial, antibacterial therapies. And indeed, some investigators continue to think that a Mycobacterium paratuberculosis contributes to the pathogenesis, although that's been in the literature for decades and has mostly been disputed in clinical trials. But we're also increasingly aware of the different contributions that the microbiome has, not only within our immunoregulatory basis to stay in that controlled equilibrium within the intestinal immune system, but also important metabolic impacts of the microbiome, the production of healthy short-chain fatty acids that are the main nutrient for the colonic epithelium. And we also recognize detrimental metabolic pathways that lead to hydrogen sulfide, which can actually be pro-inflammatory. And we know that bacteria also contribute to the barrier function and that barrier continuity. So what we've recognized between health and unhealthy is that the healthy microbiota has a high diversity with a number of species that seem to be antibacterial. And in contrast, in inflamed mucosa, a less diverse microbiota with a lower diversity and a change in a pattern of less firmicutes and more Bacteroidetes that seem to have a more pro-inflammatory pattern that are associated with the commensal on the left and then the more pathogenic on the right, associated with more disease activity. And we now have to go well beyond bacteria as when we're looking in the gut, as recently we've recognized that different fungi may have different patterns in different settings of the disease. And of course, what's been uncertain and also somewhat obscured are viruses that live within the gut, which are primarily viruses that affect bacteria, but may contribute to the diversity or lack thereof in inflamed bowels. So what we're seeing is that in the healthy individual, a more diverse spectrum of bacteria, but even within the different diseases, excuse me, there may be different patterns of microbes that we're just learning to begin to understand. And as you can imagine, when we're considering the several 100,000 genes that we have, the microbiota genes, and the different factors between the immune system and our genetics, it does require supercomputers to really assess this. And in the era preceding artificial intelligence, it's a very ripe area for investigation. Now, when we throw the environment in, it becomes even more complex. There are factors that have been associated in the environment with an increased risk of these diseases, which include oral contraceptives and an association with colitis, individuals who have the disease triggered by infections, a lot of work looking at diet preceding the development of these diseases. And I have in red here on the left, smoking and stress. For some reason around the world, cigarette smoking seems to be protective against the development of ulcerative colitis, as well as sclerosing cholangitis, as well as rheumatoid, as a negative factor in rheumatoid arthritis and Crohn's disease. Smoking can also affect, in Dr. Weiss's situation, thyroid disease. So smokers tend to get Graves' disease and non-smokers tend to get Hashimoto's thyroiditis. So we see the same environmental trigger that may move inflammatory diseases in one direction or another based on the presence of cigarette smoking. And very recently, there's been a manuscript in Clinical Gastro and Hepatology suggesting that smoking may impact on the microbiome that actually impacts in the development of colon cancers. So cigarette smoking needs to be explored more. It will be one of my models. Now, stress, on the other hand, is more challenging. You can stress an animal until they die, they don't develop colitis. But if you ask a patient what triggers their symptoms, more often than not, they're going to talk about stress. The challenge, of course, is that the same stress may have different impacts on different individuals. For instance, going to a beach may be relaxing for some individuals, but for Dr. Abreu, and where she can't jog, it's going to drive her crazy. On the other hand, a divorce may be good for one individual in the family and bad for the other. So the interpretation of stress is very challenging. Vitamin D has been across the world. If you have any disease, you're going to have low vitamin D. Even in COVID, I see now that they're associating low vitamin D with an increased risk of COVID complications. Thus far, we have not seen that replacement of vitamin D actually impacts on any of the inflammatory disorders. And so we are continuing to look at these balances of inflammatory triggers that make this, again, even more challenging to assess. And of course, as I emphasize, these are interactive. When we change our diet, we change our microbiota. We know this intuitively. We know that patterns of metabolic consequences of the diet change. For instance, when we stop carbohydrates, the amount of gas changes, the amount of flatus changes. So individuals who are on a protein or Atkins diet, their flatus tends to go away. So it's pretty obvious that diet impacts on the microbiome, and there is a cross interaction between these. And all of these make it very challenging to evaluate these diseases in humans and lead us to look for animal models as a way that we can measure and actually assay different impacts of gut microbes and the environment. And diet does impact upon the composition as well as the function of these gut microbes, as I've already alluded to. And another ex-colleague at the University of Chicago, Gene Chang, and his colleagues have demonstrated that just by changing the diet in animals who are susceptible to developing Crohn's disease or ulcerative colitis-like pictures, by feeding them a low-fat or high milk diet, that the inflammatory pattern actually changes and is associated with specific changes within the microbiome, including a new type of bacteria that's been called Bilophila wadsworthia that tend to grow up in these animals. And when you put this bacteria into another animal, actually incites inflammation. So diet can affect the microbiome, and the microbiome can certainly affect patterns of inflammation. But I've emphasized that inflammatory bowel disease, along with many of the other immune diseases, are quite heterogeneous in their phenotypic pattern. And the question is, do all of these causes, the genes, the environment, and immune system, contribute equally? And I'd say the answer is pretty obvious, no. And that may contribute to the different patterns of diseases. Individuals who have a greater genetic load versus a greater environmental load or immune changes may actually have different patterns of the disease. And this is a slide that I've again thanked Dr. Maria Abreu for. I think it represents the sequence of events that can lead to this ultimate inflammation, which may have genetic underpinnings, but become modified by epigenetic effects, perhaps related to the diet, perhaps related to hormones, as I mentioned with estrogens, and other bacterial components that can modify the immune responses. Again, the intestinal flora are contributing factors. a variety of different environmental factors, including diet, disruption of the mucosa by non-steroidal and anti-inflammatory drugs, changes in the microbiome by antibiotics or travel, and different stresses or other factors that may contribute. So it goes back to IBD, and these immune diseases are complex, and it's a chain of events that lead to the ultimate physiology. Now, when we look to the different approaches to inflammatory bowel disease over the years, the majority of our treatments have really been looking at the immune system, from mesalamine, which has anti-inflammatory properties, to corticosteroids, to thiopurines, azathioprine, 6-mercaptopurine, to other immune suppressive agents, and nowadays the specific biologic therapies that target individual cytokines such as tumor necrosis factor alpha or interleukin 12 or 23, and eventually interleukin 23, and others that are currently being studied. There has been less impact on environmental changes, although we know in children that if you take them off a regular diet and feed them with an elemental diet, you can actually resolve the inflammation as well as improve symptoms. Genetics have not yet been a target of our therapy, although, as I will emphasize, an early onset disease can be a contributor. And although we've tried antibiotics and components of antibiotics and different antibacterial therapies, and these are ongoing, we have yet to identify a specific microbial pattern or elimination of that from a clinical standpoint. So we've been utilizing through the years animal models to begin to interrogate these individual aspects of the disease, including the different genetic patterns that may develop in individuals, of course, the microbiome, as I've already alluded to. And the utility of animals has been very prominent in looking at individual components of this complex picture that leads to inflammatory bowel disease. And about 10 years ago, Warren Strober, who's been one of the preeminent mucosal immunologists at the NIH, identified what he considered to be 6 principles of an ideal model. And the answer at the moment is we do not have an ideal model. But he proposed that an ideal model would share the pathologic features, that inflammation should result from dysregulation of an immune response, that the intestinal injury should result from chronic inflammation, that there should be probes, both molecular and immunologic, that can interrogate these, that the diet and genetics might be manipulated in the animals, and that the inflammation should respond to therapeutics known to be effective for inflammatory bowel disease. But I will tell you, as of now, we do not have a model that represents the spectrum of these diseases. Now, one of Dr. Abreu and my colleagues for many years has been Balfour Sartor at the University of North Carolina, who has been looking at animal models for a number of decades. And what they've realized is that you can change the immune system in mice or rats in many different ways, by knocking out individual cytokines or knocking in HLA-B27, for instance, or there are numerous ways to modify this. But what he's recognized is that in the animal models, in the germ-free animals, IBD does not develop within these models. So it is clear that within the animal models, and likely within humans, a microbiome is going to be essential to cause these diseases. Now, obviously, we don't have germ-free humans. And so there are a number of issues and areas where the animal models don't really address all of the specifics. And to date, there are at least 80 known differences between mice and the human immune system alone, not to mention that mice are coprophagic. They eat their own feces. So it's very challenging, you know, in these species to actually study all of these aspects together, which is why I want to finish with the opportunity to look at a number of human models of inflammatory bowel disease in areas where I think that the pathogenesis can be further clarified. So we're going to start with going back to genetics. And indeed, I mentioned back in 2001 the recognition of NOD2 and other genes. Well, it does turn out that NOD2 is associated with a typical pattern of ileal and fibrosing ileal Crohn's disease. While patients with ulcerative colitis are more likely to have more NOD2 mutations, the pattern in Crohn's disease tends to be one of fibrosing ileal disease. And these individuals tend to need earlier surgery. So we should not stop looking at genetics, because these factors may actually be impacted by other genes, such as other genetic mutations, as well as have specific impacts on the environment. So these individuals who have a component or who have a combination, who are NOD2 positive and smoke cigarettes and have a serologic pattern, are more likely to have an aggressive disease pattern leading to stricturing and fistulization. There have been other genes that have been modified inflammatory bowel disease. These include HLA-B27 that allow the risk of patients with IB who are HLA-B27, while there is no risk, increased risk of ulcerative colitis or Crohn's in patients who have HLA-B27, in patients with ulcerative colitis and HLA-B27, these individuals have a greater likelihood of having inflammatory disease of the spine, such as ankylosing spondylitis or sacroiliitis. And that's in contrast to the peripheral arthritis that is not associated with HLA-B27. And in other organs, HLA-B27 has been associated with the risk of uveitis, and which is different from episcleritis that is not HLA associated in these diseases. Now, where we have seen a much bigger impact on genetics is in young children with very early onset disease. Now, children, in particular young children, have the greatest rise in incidence of inflammatory bowel disease. Both the very young, which are under age 2, but also under the age of 10 is considered to be early onset inflammatory disease. And early onset inflammatory disease has different patterns than the typical adult and adolescent onset. A greater likelihood of colonic involvement, a greater family history of disease, and a greater likelihood of disease extension have been seen in kids under 10 who develop inflammatory disease. And even more recently, children who are under the age of 2 who used to die from inflammatory sequelae have actually been recognized to have different forms of inflammatory bowel disease, and a much more severe course, as I mentioned, with a greater likelihood of family members. But in this group of individuals, the genetic contribution seems to be even greater. So as we look at the typical disease in the green in adults and adolescents, we think that there's more likely to be multiple genes involved with a greater impact on the environment. But in pediatric onset inflammatory bowel disease, we see more worse disease, greater family presence, and also a greater likelihood of single genes associated with what's known as very early onset inflammatory bowel disease, that weren't captured in these large genetic contributions that were done several decades ago. And very early onset disease can be a monogenic disorder, such as disorders associated with interleukin-10 receptor mutations. These individuals develop disease that's associated with extensive disease, penetrating disease at the lower right, cutaneous complications, pyodermas, etc. And it has been demonstrated that in these individuals, bone marrow transplantation can actually be curative. So in the typical disease, we don't see monogenic contribution. But in early onset, there are a number of different deficiencies that seem to be related to single genes, such as IL-10 genes, the FOXP3 genes, that lead to different, much more aggressive forms that may be amenable to bone marrow transplants. And indeed, this has been life-saving in individuals who have been diagnosed very early onset, who have an IL-10 receptor mutation that have led to bone marrow transplants and essentially normal. And I should emphasize that bone marrow transplants are actually being tested in different parts of the world. Thus far, there are some signals of benefit, but also obvious risks, including death. And so these studies are currently ongoing. Now, there are many additional potential human models of the disease. And I pointed out for a number of years that in ulcerative colitis and in Crohn's disease, the disease margins offer a potential area for sampling in the same individual, disease versus non-disease segments. And this is an example of a patient with ulcerative colitis, or where you see a very distinct margin. Everything distal to this margin has the same inflammatory pattern. It's diffuse and continuous. Above it is going to be absolutely normal. A biopsy from here would be indistinguishable from normal. Something is going on at this margin. There are going to be changes that we can begin to interrogate with what's going on at this junction of abnormal mucosa, likely changes in the overlying bacterial populations compared to the adjacent tissue. Similarly, when we remove a colon and create an ilioanal pouch, these pouches then over time, utilizing small intestine, which is typically more sterile over time, as the pouch becomes a reservoir for bacteria, the lining modifies, and there are metaplastic changes that the pouch mucosa becomes more colonic with increased mucus cells. So as the pouch becomes colonized, it becomes more colon-like, or colon, also histologically colonized. And interestingly, the pouch can become inflamed, which we call pouchitis, but the same small intestine above that reservoir are absolutely normal. So looking at changes in the mucosa and the epithelium, as our colleagues such as Laura Raffles at the Mayo Clinic are studying, the changes, not only the bacterial changes, but the metagenomic changes that are going on that are allowing this colonic-like mucosa to become inflamed within these pouches. And similarly, as I've emphasized in Crohn's disease, Crohn's is a more focal disease. Ulcerative colitis is diffuse continuous. Crohn's is more focal and asymmetric. So that means that there will be normal areas of small intestine, and this is an anastomosis, an ileocolonic anastomosis in a patient. We're looking actually at two parts of the ileum. This is a blind end, and looking here with the ulcerations is an individual with ulcers in the proximal afferent portion of this anastomosis. So here we have disease and here we don't. What's the difference? And we can watch the evolution of these ulcers from normal to when the bacteria become present. And colleagues, as I said, in Europe, Pierre Dans and colleagues have looked at microscopic and histologic changes and immune changes that evolve even before the histologic changes, which predate the endoscopic changes. So these disease margins are very good opportunities to monitor, to look at pathogenesis in the same individual with different normal on one side and abnormal on the other. Now, recently, we've also had some very important changes that we're looking at that are useful as potential markers. And these include different drug-induced forms of inflammatory bowel disease, including checkpoint inhibitors, and I'll mention also at the end, interleukin-17 antagonists. Now, we've recognized that individuals with different forms of neoplasia who are treated with these checkpoint inhibitors may develop immune-related adverse events. And one of the most common forms of these events is actually colitis or enterocolitis in individuals. And there are a number of biomarkers that can be interrogated looking at these different events. But what it's going to require is taking patients who are evaluated before treatment and during treatment, and then during an immune-related event in these individuals. And thus far, our oncologic colleagues who have been managing these patients have made it somewhat challenging to get to these individuals to assess them along the course of their disease. But there are many different reasons why changing the immune system, as I've emphasized before in animals, and then now in humans, might actually activate these underlying immune events. And I'm sure Dr. Weiss is examining the same thing, is why these checkpoint inhibitors are inducing thyroiditis and also even diabetes in certain individuals. In inflammatory bowel disease, it's interesting that the pattern of inflammation in checkpoint inhibitor colitis and enteritis follow the exact same spectrum of inflammatory bowel disease, to diarrhea with a normal appearing mucosa, to deep ulcerations, to a more diffuse continuous disease, to more focal disease. And we have yet to assay enough of these individuals to identify the immune predisposition, the different underlying microbiome that may impact on this, and also the different histologic findings. So indeed, individuals who have a more diverse microbiome are less likely to develop the immune-associated colitis. And on the other hand, patients who do develop these immune-related events actually have a better outcome as far as their cancer is concerned. So both the endoscopy and the histology are very much like ulcerative colitis and Crohn's disease. And indeed,
we only have 2 more minutes.
I will be done in 2 minutes, Roy, thank you. And in these individuals, we have differences in the microbiome that need to be monitored to see if this is therapeutic or potential. So a lot of reasons the microbiome may impact on this. So to conclude, and I'm going to skip interleukin-17 induced colitis, a slide that Dr. Abreu has been familiar with that her mentor, Dr. Targan, and she developed more than 30 years ago. The different patterns of these diseases, we're now looking beyond genetics and immune markers to metabolic and other microbiologic markers that lead to these as Crohn's diseases and ulcerative colitis. And we need to look beyond the individual cytokine and immune patterns to look at the nodes of the exposome and how these interact together and interrogate these as a conglomerate rather than individual. That's going to allow us to understand this complex pathogenesis. And as I say, integrating both animal models and then human models as well to take us beyond the animal models are going to help us understand these diseases in the future. So I hope I've given the general audience a more focus on these diseases, our understanding and our lack of understanding, and how we can continue to utilize both animals but also human models to continue to understand them even better. So with that, if Dr. Weiss has any questions, hey Maria, good morning. Happy to try to address questions.
Dr. Hanauer, it was truly a privilege hearing this tour de force lecture on inflammatory bowel disease. And while it may be true that Dr. Kersner, may rest in peace, was the grandfather of gastroenterology, you are indeed the father. And you have taught me not just about IBD, but a lot about gastroenterology, for which I will be forever grateful. We are grateful to have the matrilineal lineage of IBD in Miami. So Dr. Abreu and her team have also been amazingly wonderful as well. But this has been a special.
Maybe half of my slides were hers. I don't know.
But Steve, you're great, and you certainly affected more than just me in terms of careers, and we owe you a tremendous amount of gratitude. So given the fact that it's after 1 o'clock, we'll collect any questions on the chat, and we'll be sure to send them to you, Steve, and safe journey home. Thank you so much for coming to Miami.
Maria still owes me a dinner.
Oh, and we'll get it to you, don't worry. Okay.
You know, everything's pickup now.
Okay, thank you, thank you.
Thanks, Maria. Be well.
And for the residents, we'll try. For the residents, please see the QR code. We'll leave it up.